So to put all of this together, let's do a Q&A. What do you test for? Those are the lists. Now, what's an agnostic marker? An agnostic marker is something that you test for which works across indications. It works in stomach, it works in colon, it works in pancreas, and so on and so forth. So there is a set of markers called agnostic markers, which again you can test for. What's the most common chemotherapy backbone? It's called FOLFOX or Capox, it's capecitabine, or 5-FU with oxaliplatin. That's the most common backbone that we would use. Have targeted therapies improved survivals? Yes, we have a handful of targeted therapies that we can use in these patients which have improved overall survivals. And that is a list of some of the targeted therapies that we have access to. Zolbetuximab is not at this point in time. How long do you treat these patients? Now, if your patients are responding well and their quality of life continues to be maintained with treatment, then you continue to treat them as long as they are well. What else? As I said, tissue agnostic biomarkers. Sometimes we do something called as next generation sequencing and look for some targets. The yield of such a technique is very, very low, but that can sometimes give rise to a choice of doing some off-label therapies with these drugs. Whom should you avoid treating? I think this is an extremely important question. Anybody whose performance status is 2.5 or below, that means they are not able to do at least half of their daily activity. These are patients who will do very poorly with your systemic therapy. You should not be heroic to say, I'm going to start chemotherapy and this patient will walk in the next couple of weeks. It may actually be the other way around. That patient might end up being on a stretcher or wheelchair bound if you choose the wrong patient. So as they say, wisdom is to know when not to treat, and these are two important situations where you should not be treating. And then finally, the patient's wishes. If you've got an 85-year-old patient, you've got good performance status, good organ function, but you tell them the numbers, they will give you a nice gentle smile and say, thank you, doctor, I'm happy to be on just symptomatic treatment. So patient's wish is very important. What you always need to keep a watch on is physical toxicity and, very importantly, financial toxicity, because pushing your patients to take something that is really not financially viable for them can end up changing them from a fat bank balance to no balance at all. And this is something that we should be very cognizant about and know when and where to stop, when and where to talk. Thank you so much.